Hello, cohort 2027. This is Dr. Peters Harris again. Today we're going to talk about module L and M. We're going to go through acid-base physiology and some of the pulmonary system pathophysiology. So although I combine both modules again to give me a better understanding and organization of the learning objectives, the first part we will be going over acid-base physiology. Acid-base balance is one of the most tightly regulated parameters in human physiology. Even small deviations in blood pH can impair enzyme function, oxygen delivery, and cellular metabolism. Because of this, it makes it a very high yield topic for the PANCE and any board test that you're going to probably ever take. So this is all very, very important information. It's going to be high yield, a high percentage you will see throughout your didactic phase, throughout your clinical phase, and most definitely on your PANCE. So the first part of the lecture, we're going to talk about acid-base balance systems. I'm going to compare renal and pulmonary mechanisms in supporting acid-base homeostasis. I'm going to also talk about metabolic versus respiratory, the different disorders, and we're going to be able to differentiate between metabolic and respiratory acid disorders. Going to also go over ion gap and how to calculate it and how to interpret the ion gap to aid in diagnosing metabolic acidosis. And then I'll give you some clinical manifestations so you'll be able to recognize the clinical manifestation of acid-base imbalances. So first, let's go over some terminology. pH. This is the measure of hydrogen ion concentration in a solution. It usually reflects acid-base status of the blood, with a normal pH being 7.35 to 7.45. Acid, and this is a substance that donates a hydrogen ion. It will lower the pH when added to a solution. Base, substance that accepts hydrogen ions and produce hydroxide. This will raise the pH when added to a solution. And then buffer. This will be a system that resists changes in pH. It's temporary. It will bind and release hydrogen to stabilize the pH, but it's only for a temporary moment. So this is the partial pressure of carbon dioxide. So PA or small a CO2. This will reflect alveolar ventilation and respiratory components of acid-base balance. It is inversely related to pH, meaning when your PaCO2 is elevated, you're likely going to have a respiratory acidosis. Partial pressure of oxygen, the PaO2. This measures the oxygen dissolved in arterial blood. This assesses effectiveness of the pulmonary gas exchange. So this number will actually allow you to understand how well you're exchanging gas, oxygen, carbon dioxide, and we'll talk about it a little bit later. So bicarbonate, and this is the primary metabolic buffer that's regulated by the kidneys. It determines metabolic components of pH. So a decrease bicarbonate usually equals metabolic acidosis. Ion gap, this is something that we will calculate. It's a calculated value identifying unmeasured ions in metabolic acidosis. Calculating the ion gap will help differentiate high ion gap versus non-ion gap metabolic acidosis. This slide discusses the Henderson-Hasselbalch equation. This is an equation to calculate the pH. So pH is equal to 6.1 plus the log of the bicarbonate divided by 0.03 times the partial pressure of carbon dioxide. And that's basically what this sentence states. The pH increases when the bicarbonate rises or the partial pressure of carbon dioxide falls, and it decreases when the opposite occurs. So the physiologic interpretation, so you have bicarbonate, which will be your numerator, and you have the partial pressure of carbon dioxide, which is your denominator. The numerator, or the bicarbonate, is the metabolic component, and that is regulated by the kidneys. The partial carbon dioxide is the respiratory component, and it's regulated by the lungs. pH reflects the balance between the renal and the pulmonary function. So this slide discusses homeostasis and its correlation with pH, so how they are connected. Homeostasis, remember, is the ability to maintain a stable internal environment despite any external or metabolic changes. It requires tight regulation of pH, electrolytes, temperature, and gas exchange. pH as a homeostatic variable. The blood pH reflects the balance, again, between the acid production and the acid elimination. So again, a normal range is 7.35 to 7.45, and this is essential for enzyme activity and cellular function. Disruption of the pH. There are different things that can cause the pH to increase or decrease. So metabolic activity consists that constantly generates acid, like for instance, in sepsis, you can have elevated lactic acid that can change your pH. Without correction, pH will shift and impair oxygen delivery, cardiac function, and metabolism. So things that can, or systems that can compensate and try to keep the pH normal as much as possible. You have two systems, again, the lungs and the kidneys. The lungs regulate pH rapidly by adjusting ventilation, which will affect your partial pressure of carbon dioxide. Kidneys provide a long-term control by adjusting the hydrogen excretion and the bicarbonate levels. So the lungs compensatory system is short term and probably faster, and the kidneys is a long term and probably a slower process. So clinically, how does this correlate? If you have a failure in any one of the compensations, so the lungs or the kidneys, you'll end up with an acid-base disorder, which we'll go into detail a little bit later. And persistent pH imbalance is a loss of homeostasis. And if the body isn't compensating, it will further go into organ dysfunction. And this is just a little cartoon how pH is regulated by the lungs and the kidneys. So let's discuss the relationship between the pH and the hydrogen ion in a little bit more detail. So again, the pH measures the hydrogen ion concentration. Small changes in the hydrogen ion can cause a large change in pH. They are inversely related. So increased ion concentration will cause a decreased pH and therefore cause acidosis. A decreased hydrogen concentration will allow for a increase in pH and that will cause alkalosis. So hydrogen ions are produced continuously by normal metabolism. There's a tight regulation of hydrogen. Again, this is essential for enzyme activity as well as cellular function. And again, the regulatory systems that control this will be the lungs will regulate the hydrogen indirectly by controlling the partial pressure of carbon dioxide or the carbonic acid, and the kidneys will regulate the hydrogen directly via excretion and bicarbonate conversion. And I will show a diagram a little bit later to kind of enforce this. So another system that can also help to keep the homeostasis and the balance is called the buffer systems. And we have three major buffer systems. One is composed mainly, or it focuses on bicarbonate. Another one focuses on the regulation of phosphate. And the third focuses on protein and or hemoglobin. So we're just going to talk about this in a little bit more detail. So what is a buffer and what does it do? The buffer system, again, helps to regulate the hydrogen ion. It attempts to resist any sudden changes in the pH. It does this by binding or releasing hydrogen ions. Because remember, if hydrogen is increased in concentration, pH is going to decrease. So once the buffer system senses this, it will either bind the extra hydrogen, or if it needs to adjust the pH in the other direction, it will release some of the hydrogen. These buffer systems are immediate, meaning they're fast acting. They're like the first response, but they're short-term pH stability. Usually these will come in first, then you will have the lungs if it needs to compensate via the lungs, and then the last system would be the kidneys. So when acid is added, again, increased hydrogen ion, the buffer binds to excess hydrogen. This helps to limit the fall in the pH, so it prevents rapid acidosis. When a base is added and the hydrogen ions are decreased, again, the buffer will release hydrogen ions, and this prevents a rapid increase in the pH, and it prevents alkalosis. Things to really know, these buffers, they do not eliminate the acid or the base. They just kind of help to buffer the system. They buy time for the lungs and kidneys to kick in and correct the pH. So the three systems, buffering systems, one is a bicarbonate buffer. It is the most important buffering system. It is located in the extracellular space, and I'll show you a diagram a little bit later about that. This is the equilibrium equation that goes with how bicarbonate functions in order to stay in homeostasis. I put this up here for you to know for your just viewing pleasure. I will not quiz you on this, and from what I reviewed through PANTS, they're not going to ask you an equation about this, but basically it just shows how carbon dioxide plus water will equal carbonic acid, which is a weak and unstable acid formed when carbon dioxide dissolves with water. Then it can turn into the hydrogen ion in the bicarbonate. Again, this system, the lungs regulate the carbon dioxide and the kidneys regulate the bicarbonate. The next system is the phosphate buffer. It does something very similar. This is important in the renal tubules for hydrogen excretion. This is also a extracellular buffer system. The third system is protein. It is unique in that it can be part of the extracellular system as well as the intracellular system. The intracellular system is more related to the hemoglobin buffer, but it uses amino acids to bind and release hydrogen. And with the hemoglobin, it buffers the hydrogen ion inside of the red blood cell. So the clinical integration that goes along with this, again, the buffer system will act immediately. The lungs usually will compensate within minutes, and the kidneys, which is a definite correction, can take hours to days, but again, that's a long-term solution. And I know this slide is very busy, however, it kind of summarizes, the previous slides. Again, you have your pH. It should be normal between 7.35 and 7.45. You have the Henderson-Hasselbalch equation that helps you come up with how you derive the pH. These are normal values that you'll see in an arterial blood gas. Your pH, again, you want it to be 7.35 to 7.45. Your partial pressure, carbon dioxide, is 35 to 45. And I always remember in normal, it should be similar to the numbers in the pH. You have your bicarbonate, which is normal range is 22 to 26. Your partial pressure of oxygen is 80 to 100 millimeters per mercury. And this is the arterial oxygen saturation. It should be greater than 95%. So this will give you an accurate reading of how much oxygen is circulating within the arterial blood. And then this over here is just the 3 buffering systems that we already talked about. It shows the equations, the equilibrium equations. It also discussed how after the buffer system, you may have the lungs come in and compensate, as well as the kidneys. Again, the bicarbonate buffer is a very important extracellular buffer. The phosphate buffer is in the renal tubules, is also an extracellular buffer. And then, like I told you, the protein buffer, which is based off of albumin, is normally an extracellular buffer. However, protein buffer can be in the intracellular space, and this is usually with hemoglobin. And this slide just, shows a picture. Basically, your kidneys are the long-term area that will fix any acid-base disturbance. It's one of the most important systems for long-term correction or definitive correction. And this is done at the level of the nephron, where you will have bicarbonate reabsorption, hydrogen secretion, and ammonia production. So if you review this in anatomy, this Bowman's capsule comes out of a portion of your kidney, and it is made up of this, system that helps with making urine and also excreting and secreting different ions in order to allow for elimination of toxins or elimination, in this case, of any type of acidosis. So what this actually shows, in your proximal convoluted tubules, you will have the reabsorption of bicarbonate. So this is your extracellular space. The bicarbonate is reabsorbed, taken out, but hydrogen is actually secreted within the tubules. And the reason it's secreted in is because the kidneys is trying to push that acid out, or, is trying to correct the excess hydrogen. You also have reabsorption, some in the distal convoluted tubules, as well as more secretion, meaning the hydrogen goes into the tubules in order to be excreted out. And so just to break down what that diagram was attempting to show, the renal regulation of acid-base balances, it has like 3 main components. You have the bicarbonate reabsorption. 85% of the filtered bicarbonate is reabsorbed in the proximal convoluted tubules via the sodium hydrogen exchanger. Carbonate anhydrase catalyst the conversion of carbon dioxide plus water to carbonic acid. It will dissociate to regenerate bicarbonate. This also takes place in those tubules. Hydrogen secretion. So the distal nephron actively secretes hydrogen ion via the hydrogen ATPase and hydrogen potassium ATPase pumps. This is upregulated in acidosis and downregulated in alkalosis. So remember, like what I was telling you, if you have acidosis, your acid is high, your hydrogen, you have excess hydrogen. In order to balance that, your body will secrete the hydrogen into the distal nephron so that it can be excreted out into your urine. You do have some other acids and ions that may help. So phosphate and ammonia buffers can also secrete hydrogen ions. And another important function for the nephron or the kidneys in regulating acid base, it can produce ammonia and ammonium, which is the NH4. The proximal tubule cells produce ammonia from glutamate metabolism. It diffuses into the lumen and combines with hydrogen to form ammonium, which is trapped and then excreted. So this system is normally used in conditions where they've had chronic metabolic acidosis. So just one of the key clinical concepts that I've continued to say, and I've been pretty repetitive about it. Renal compensation is the slow compensatory response. It will take hours to days. The kidneys can adjust bicarbonate reabsorption and hydrogen excretion to correct pH. Unlike the respiratory compensation, which only takes minutes, renal changes are more complete, but they usually will take 3 to 5 days to reach the maximum effect. So just, always remember that, when you're out practicing, you may have a patient that has an acid base disturbance. I just don't want you to get discouraged. It does take, at least 3 to 5 days before you even notice a response. I can remember patients with severe metabolic acidosis that's in the ICU, and it usually takes about 48 to 72 hours before we start noticing significant changes in their pH. Now we have, other mechanisms to help them. Again, the lungs can kind of help compensate, and a lot of times we would increase their respiratory rate if they were on a mechanical ventilation. So next, we're going to talk about the 4 primary acid-base disorders in a little bit more detail. This is 2 different little diagrams. This one, the acid-base imbalance, just a cute little diagram, shows, there's a balance that we're trying to keep. Normal pH is 7.35 to 7.45. Anything less than 7.35 is acidotic. Anything greater than 7.45 is considered alkalotic. The compensation mechanisms is either with the lungs, you're going to blow it off, or you're going to excrete it out with the kidneys. And these are the 4 primary types: the metabolic acidosis, respiratory acidosis, metabolic alkalosis, and then respiratory alkalosis. This diagram or image shows is mainly for respiratory pH disorders. You have an x-axis that has the bicarb on there, and then you have a y-axis that is tracking the CO2 or the carbon dioxide, and you're plotting the pH. And so if you're over here and you're 8, your bicarb is 60. This shows a respiratory alkalosis because your bicarb is going up, however, your CO2 is very low. So alkalosis, you'll have increased ratio, your bicarb is elevated as your CO2 is decreased. And this can be reflected, in their respiratory status. So let's jump into the different disorders. Start off with metabolic acidosis. So by definition, the pH is less than 7.35. Primary disturbance, meaning you're going to have a low bicarbonate as well. This is metabolic in nature, and the origin can be renal or from GI source. So the pathophysiology, there's a loss of base or acid gain. You have excess acid production. This can be seen again like in lactic acidosis or ketones, or there can be a loss of bicarb. And that's why I was saying it was like a GI origin as well. So diarrhea, but also you can have a loss of bicarb and renal tubular acidosis. There's impaired acid excretion as well. That can also be a cause, and that's usually seen in renal failure. So in a metabolic acidosis, when you're looking at an ion gap, and the ion gap is sodium minus chloride plus bicarb, we calculate this number from the serum chemistry. So it's two things when you're having patients that you're thinking that have an acid-base disturbance. You'll look at their chemistry, their Chem 8, but also you may have to get a ABG, arterial blood gas. So in metabolic acidosis, the ion gap is high, meaning an unmeasured acid has been added, and that's usually due to DKA, lactic acidosis, or toxins. I have seen toxins contribute to an increased ion gap. I remember in residency, I was moonlighting in the emergency room, and I had a patient that came in that had an increased ion gap, and they weren't a diabetic, and their lactic acid was normal. However, they presented with renal failure. They had ingested antifreeze. The guy was homeless and an alcoholic and had ingested a lot of antifreeze, and that's usually when you'll see that presentation. So compensation for metabolic acidosis, again, is a respiratory response. It's rapid, so you'll get hyperventilation. You're doing this to decrease the partial pressure of carbon dioxide. So you're going to they're trying to blow all of it off. This can also be calculated through a formula called the Winner's formula, which is the partial pressure of carbon dioxide equals 1.5 times the bicarbonate plus 8 plus or minus 2. And I'm going to explain this in a case a little bit later. The importance of this, if a person presents or a patient presents with metabolic acidosis and their body's natural response is to try to compensate with a respiratory response. If you calculate this formula, if you calculate where the partial carbon dioxide should be, like the normal range for that person that has metabolic acidosis, if you don't get this number through the calculation, or if it's off, that will give you an indication that they may have some underlying respiratory issue that they can't fully compensate. And so you actually may present with a mixed picture. So you could have a metabolic acidosis and like a respiratory alkalosis. You'll end up with a mixed picture. But like I said, I'm going to give you a case to kind of walk through a little bit later. So clinical correlation to this metabolic acidosis, some of the key findings that you'll find on clinical exam, they will have these Kussmaul's respirations, which is basically a pattern of deep, rapid, and labored breathing. Sometimes it is termed like air hunger, but it is the compensatory mechanism for severe metabolic acidosis. The patient may also present with extreme fatigue and confusion. A lot of times they will have electrolyte abnormalities such as a hyperkalemia. And you have to be very careful with these patients. Severe acidemia can lead to cardiac issues, so it can decrease cardiac contractility. Next, we're going to discuss metabolic alkalosis. By definition, the pH is greater than 7.45. There's an increase in bicarbonate. This is strictly metabolic in origin. You can have, for the pathophysiology, it's usually due to some like GI loss from vomiting, or if your patient has a NG tube, prolonged NG tube. Diuretics can also contribute to it. It can cause some bicarbonate retention. And then certain endocrine disorders like hyperaldosteronism will have an excess mineralocorticoid, can also contribute or cause an alkalosis. For this little part, you just need to know volume and chloride status can be affected. So with the alkalosis, you will monitor your chloride. If the chloride is low, the volume may be low. A lot of times in metabolic alkalosis, there is a volume depletion. So this is kind of normal. You may see your sodium and your chloride down and just a typical volume depletion. But if in the volume depletion they have an alkalosis, you will probably see the chloride down. Compensation, again, is respiratory. So what happens is the opposite of metabolic acidosis. With this one, if the pH is elevated, you will hypoventilate, so decrease your respirations in order to build up the partial pressure of carbon dioxide. You are expected that the carbon dioxide increases by about 0.7 millimeters per mercury per 1 milliequivalents per liter to the bicarb. So I have a slide that kind of breaks it down. If you're ever looking and trying to calculate if your patient is adequately compensating, you can, just multiply the partial pressure of carbon dioxide by 0.7 to see if it's going to give you an increase in the bicarbonate. This compensation mechanism is incomplete because it can lead to hypoxia with the hypoventilation. So how do we clinically correlate this? A lot of times these patients will present again with other electrolyte abnormalities. They can have hypokalemia, they can have hypocalcemia symptoms, so they can have the tetany or the paresthesias around the mouth. Because of these electrolyte abnormalities, it can also have arrhythmias. And then they can have decreased O2 delivery. There could be a left shift in the oxygen hemoglobin curve. So now I'm going to switch gears from the metabolic to respiratory acidosis. So again, with acidosis, pH is less than 7.35. However, with the respiratory component, you're more focused on the partial pressure of carbon dioxide as opposed to bicarbonate. So you will have a decrease pH and an increase carbon dioxide. This is respiratory in origin, and a lot of times it's due to some type of alveolar hypoventilation. So the pathophysiology of this, you will have a lot of carbon dioxide retention. The carbon dioxide added with the water, of course, will give you the carbonic acid, which will in turn be broken down to the hydrogen and the bicarb. Therefore, you will have an increase in hydrogen ion. So increased carbonic acid will lower the pH. Just remember, increased hydrogen ion causes an acidosis, causes the pH to be lowered. And then there's a failure to eliminate carbon dioxide via the lungs. So some of the causes of this can be like a hypoventilation state. COPD is the most common chronic cause. You can also see this with opioids and sedatives. You can see it with neuromuscular disease such as ALS and myasthenia gravis. You can also see it with airway obstruction as well as chest wall restriction. Two of the ones that I used to see a lot in residency, other than COPD, I would see hypoventilation due to obesity. So the compensation for respiratory acidosis is a renal response. Again, it's a slow process, but it's going to increase the reabsorption of bicarbonate and therefore also increase the excretion of hydrogen ions. So the bicarbonate comes in, it's reabsorbed, it will pull some of that hydrogen back into the tubules to where it can be excreted out into the urine. There is a ratio, just like I showed you on the previous slide. If it's an acute process, bicarb will increase about 1 milliequivalents per liter per 10 millimeters of mercury as the partial carbon dioxide increases. If it's chronic, this rate is around 3.5 per 10. Still takes about 3 to 5 days for a maximum effect. Your patients may present with a headache, confusion, somnolence, hyperkalemia. Their skin may be warm, flushed due to some vasodilation. In severe cases, they can have arrhythmias, coma, and for chronic COPD, they can also have a near normal pH due to their prolonged renal compensation. So they can actually fool you. So in the case, like I was telling you a couple slides back, when you're calculating this, someone that has an acute metabolic acidosis and you're trying to see if they're compensating appropriately, the numbers may be skewed if their respiratory status or their system already has an underlying disorder. So in patients that have chronic COPD, they can have a near normal pH, and that's due to their renal compensation. However, if this patient has COPD and develops a metabolic acidosis, they're not going to have an adequate compensation. And so they may present with a mixed picture. You may see a little bit of metabolic and respiratory in those patients. And lastly, we're going to talk about the respiratory alkalosis. Definition: pH is greater than 7.45. You have a lower partial pressure of carbon dioxide, is respiratory in origin. This is normally due to hyperventilation. The pathophysiology, you have excess CO2 elimination due to the hyperventilation. You're blowing off a lot. This will drop your partial pressure of carbon dioxide, also dropping your carbonic acid, which drops your hydrogen concentration. Therefore, it will give you an elevated pH. Causes: this can be seen in anxiety, pain, fever, PE, sepsis, pregnancy, high altitude, and salicylate toxicity. Compensation, again, is renal. By the same process, the bicarbonate is reabsorbed. Hydrogen ions are excreted. In this, the correction may be a little bit faster. So bicarb will decrease by 2 milliequivalents per liter per 10 millimeters of mercury as the partial pressure of carbon dioxide decreases. And if it's a chronic process, this decreases by 5. Again, it still takes 3 to 5 days. Some of the clinical symptoms that patients may present with include lightheadedness, dizziness, perioral and extremity paresthesias, Kennedy, which is due to hypocalcemia. It can basically it's triggering some involuntary muscles spasms, cramps. You can also see palpitations and syncope in very severe cases. So it's just the diagrams that I showed before going through the primary types of acid-base imbalance. And then this is the summary slide that may be a little bit easier to digest. Metabolic acidosis, again, decreased pH. You're going to have a decreased bicarb. Compensation will be hyperventilation to get that partial pressure of carbon dioxide down. Different causes, decay, lactic acid, renal failure, toxins. Like I said, the ethylene glycol was the one that I saw in residency. As compared to the metabolic alkalosis, you have increased pH, increased bicarbonate, and the compensation is hypoventilation. You're going to slow the breathing down. This can be caused by vomiting, NG suction, diuretics. And then next you have the respiratory acidosis. You have a decreased pH, elevated partial pressure carbon dioxide. Compensation is renal, so you will increase your bicarbonate reabsorption. This can be seen in COPD, CNS depression, neuromuscular disease, some airway obstruction. And then for the respiratory alkalosis, you have an increased pH. There's a decrease in the partial pressure of carbon dioxide. Compensation is through renal excretion. We're going to decrease your bicarbonate. You will see this is caused by hyperventilation. Same with anxiety, pain, fever, PE, pregnancy, sepsis, and high altitudes. So next, I'm going to dive into talking about the ion gap and how we use it as a diagnostic tool. So I stated earlier that there is a formula for your ion gap. It is sodium minus chloride plus bicarbonate. Normal is usually 8 to 12 milliequivalents per liter. Things that can increase your ion gap in the state of an acidosis. We have this mnemonic called mud pals. It's been around for many, many years. So it's the mud pals is methanol, uremia, DKA, propylene glycol, isoniazid, and iron, lactic acidosis, ethylene glycol, and salicylates. So when you have a patient that has a metabolic acidosis, you're going to calculate their ion gap. That's the second thing you'll do. And you want to determine whether it's an elevated ion gap acidosis or a normal ion gap acidosis. And an elevated ion gap acidosis is basically what we talked about in the previous slides. And a normal ion gap acidosis, it can be loss of bicarb or impaired renal hydrogen excretion. This may be your clue that the patient may be having some renal disease. It can also be seen in diarrhea. Things that you will monitor, the chloride on the chemistry and a elevated ion gap is normal. Chloride on the chemistry and a normal ion gap acidosis can be increased. You want to calculate the osmolar gap if toxic ingestion is suspected. And I'm not going to go into details of that at this point, but just know probably later in your curriculum you will go into details. And I know probably when you're on your internal medicine rotation, or if any of you do a pulmonary rotation, you'll also go into some further detail. In a normal ion gap acidosis, you can check the urine ion gap to differentiate between renal and GI. And again, these are two things that normally you'll see in an inpatient rotation in an ICU patient. So this slide discusses the interpretation of an ABG. So if you have a patient that's acidotic, or if you have a patient that's on a ventilator, a lot of times you're going to get these serial ABGs, usually daily, but sometimes if you're having, if the patient is really sick, you may get these ABGs anytime you make any adjustments to the ventilator. But when you have an ABG, one of the ways you start to interpret it, the first thing you'll do, you assess the pH. So it will have the pH on there. The second thing you will do is to check the carbon dioxide and bicarb levels to identify, the cause. The third thing you do is the opposite system responding appropriately. Now that's when you would do that winner's formula. If it's a metabolic acidosis, the fourth thing you would do is to calculate your ion gap. And then we didn't talk much about this, but the change in the ion gap and the change in the bicarb gives you the delta-delta. This helps you to look for mixed disorders. I'm not going to go into detail about that, but I just want you to be aware of it. I'm not going to test you on that. And this little chart down here gives you the expected compensation. It also gives you the formula, like the winner's formula. It also gives you a time frame of when you would start seeing the compensation. Okay, to sum everything up, let's try to go through a case and work through it together. So you have a 24-year-old woman with a type 1 diabetes, presents to the ED with nausea, vomiting, abdominal pain, and rapid breathing for 24 hours. She admits she ran out of insulin 2 days ago. On exam, her vital signs, heart rate is elevated at 118, blood pressure is 98/60, respirations 28, deep and rapid, temperature is 37.8 degrees Celsius, and oxygen saturation is 98% on room air. On your physical exam, her mucus mucosa are dry. She has a fruity acetone breath, and she's doing the Kussmaul's respirations. So your initial labs likely would have the chemistry first. Then you would want to get the arterial blood gas. But sometimes in the ER, all the information comes to you at one time. So The arterial blood gas shows a pH of 7.18, PCO2, partial pressure carbon dioxide of 22, a bicarbonate of 8, and basic metabolic panel shows a sodium of 138, chloride of 100, bicarb of 8, glucose is 520, and creatinine is 1.4. So in the first step of this patient's case, you want to assess the pH based on what was given. pH was 7.8, so you know it's an acidemia because it's less than 7.35. The next step, you're going to identify the primary disorder. And you do that by looking at bicarbonate and the partial pressure carbon dioxide. Both are low. So based on this is a primary metabolic acidosis. Next, you want to determine if the patient is compensating adequately. So you would use your Winner's formula and put your numbers in. So expected partial pressure of carbon dioxide equals 1.5 times the bicarbonate plus 8 plus or minus 2. So when we put all our numbers in, you get 20 plus or minus 2. The normal PaCO2 is normally 18 to 22. So if in between this range, this indicates appropriate respiratory compensation. There is no mixed respiratory disorder. The fourth step is to calculate the ion gap. And this is to see if it's a high ion gap versus a normal ion gap. And remember, with the high ion gap, you have certain disorders, and DKA is one of them. So you would plug in the ion gap formula, which is ion gap equals sodium plus chloride. Sodium minus the chloride plus the bicarbonate. And when we plug those numbers in, we get 30. Remember, a normal ion gap is 8 to 12. So this is really, really high. So your final interpretation, you have a high ion gap, metabolic acidosis. The compensation is appropriate with the hyperventilation. That's why the patient's respiratory rate was so high. And your likely diagnosis is DKA. And this is just a summary of some clinical manifestations of acid-base imbalances. For acidosis, it can affect cardiovascular system, the neurological system, respiratory system, and the metabolic system. We kind of went through all of these. You can just review them. And then the same thing for your alkalosis. It affects all these systems. And we touch bases on a lot of them. Just want you to be mindful of the metabolic implications with both, and how they may present. Like how both of them were talking about changes in your potassium. One, they may present with hyperkalemia. The other, they may present with hypokalemia. But yeah, you can go over those at your leisure. Okay, so now I'm gonna jump into Module M, which was the pulmonary system pathophysiology. I didn't list all of the 13 instructional learning objectives, but we will cover obstructive disease, restrictive disease, pulmonary vascular disorders, pulmonary infections, TB, and the lungs' roles in the acid-base compensation, which was mainly presented in Module L. Although I didn't list all the instructional objectives, I will put the instructional objective, like the IOL and the number, at the bottom of the slide so that you'll know where to find it in your syllabus. So let's jump into it. We're going to start off talking about the structure and function of the pulmonary system. This is made up of lungs, airways, and respiratory muscles. The structure is a pair of spongy organs in the thoracic cavity. The right lung has 3 lobes, the left lung has 2 lobes, and a cardiac notch. Alveoli lined with type 1 and type 2 pneumocytes make up these lobes. The lung's function is to, its primary role is in gas exchange, so oxygen uptake and carbon dioxide elimination. The type 2 cells also produce surfactant, and this prevents the alveolar from collapsing. Next, talk about the airway. The structure of the airway, you have an upper and a lower. The upper airway consists of the nasal cavity, pharynx, and larynx. The lower is the trachea, bronchi, bronchioles, and alveoli. Also have cartilage in the trachea and the bronchi. And you also have some smooth muscles in the bronchioles. The airway's function is to conduct air to the alveoli. It's to keep the air warm, humidified, and filtered. Bronchiolar smooth muscle helps to regulate airflow resistance, which this is a key component in asthma and COPD. And then you have the respiratory muscles structure. You have a diaphragm, which is the primary muscle of inspiration. You have external intercostals. They kind of assist with inspiration. You also have the accessory muscles. And then you have the abdominal muscles that assist in forced expiration. Function of the respiratory muscles is to generate negative intrathoracic pressure. This enables ventilation, inspiration, and expiration, and it increases ventilation during exercise or acidosis. Okay, in this slide is just 2 diagrams basically discussing or showing what I discussed on the previous slide. In this diagram, you have your trachea that breaks off into your bronchi, the 2 branches. It then travels, becomes bronchioles. At the end of the bronchioles are your alveoli. Those are little small sacs where gas exchange occurs. You also have your diaphragm that helps to assist. Again, your right lung has 3 lobes, and this says 3, but it's 2 and a cardiac notch. Over here, just showing the a diagram that shows some of the muscles in inspiration and expiration. In inspiration, you have some principal muscles like the external intercostals, as well as your diaphragm that help with the breathing in order to create that negative intrathoracic pressure. And then the accessory muscles help. And then with your muscles of expiration, you can use some of that internal intercostals. They can also, help. Okay, next I'm going to jump into talking about a little bit of the respiratory physiology, and trying to correlate the ventilation, gas exchange, and acid-base balance. These are all things that are very important in the pulmonary system. So, and this correlates to your instructional learning objective 1. So, mechanism of breathing, which is known as ventilation. What happens? The diaphragm contracts, which causes increased thoracic volume. Intrapulmonary pressure will decrease and air flows into the lungs. On expiration, there's a passive elastic recoil. The accessory muscles and abdominal muscles are usually used during forced breathing. All of this helps to determine the partial pressure of carbon dioxide elimination. So let's talk about a little bit of the gas exchange, what occurs in the alveoli. This occurs at the alveolar capillary membrane. Oxygen diffuses into the blood and carbon dioxide diffuses into the alveoli. This requires a thin membrane, and it covers a large surface area. This exchange is dependent on VQ matching, and I will discuss that in a little bit more detail in the next slide. So alveoli equals gas exchange. And last, you have your acid-base balance, and I went into great detail at the beginning of the lecture with this. So carbon dioxide equals an acid, meaning it will cause more hydrogen to be in excess. So increase partial pressure of carbon dioxide will cause a decreased pH. Remember, like I said, decreased pH is normally due to increased hydrogen ion. This is known as a respiratory acidosis. If you have a decreased partial pressure of carbon dioxide and an increased pH, that is alkalosis. The lung can compensate, as previously stated, within minutes. Kidneys are slow, but it is normally a definitive correction. And I just put this at the very bottom, and I'm sorry to overstuff your slides. It was just, I was trying to condense the PowerPoint so that it wasn't 200 slides. But anyway, the clinical integration. So in hypoventilation, which we talked about, you can have a respiratory acidosis. This can be seen in conditions like COPD or neuromuscular disease. If you have a hyperventilation, there is a respiratory alkalosis. This can be seen with a PE or anxiety. And if you have a metabolic acidosis, you're going to have a compensatory hyperventilation, and that will be seen in DKA. So ventilation perfusion, which is the VQ mismatch. What is ventilation or VQ? So the VQ is ventilation divided by perfusion. Ventilation is the amount of air that's reaching the alveoli. Perfusion is the blood flow reaching the capillaries, the alveolar capillaries. Normal VQ is around 0.8. Effective gas exchange requires matching the airflow and blood flow at the alveolar level. So why does VQ matching really matter? Again, oxygenation depends on both ventilation and perfusion. Even if one is normal, gas exchange will fail if the other one is impaired. And this is the most common cause of hypoxemia in lung disease. So I think what's important from this is that airway does not automatically equate to gas exchange. You can have an airway, but if your alveolar are damaged or impaired, you won't have appropriate gas exchange. So I'm gonna just talk briefly about some different types of VQ mismatch where you wouldn't have appropriate ventilation and perfusion. So the first one we'll talk about is if you have a low VQ, and this is like in a shunt, if you have a shunt. So let me go through it. In this state, you have greater perfusion than you do ventilation. Blood is able to reach the alveoli, but the alveoli are poorly ventilated, so oxygen cannot adequately diffuse into the blood. Examples of this is pneumonia, pulmonary edema, COPD, and atelectasis. What we see from a physiological standpoint, there's decreased alveolar oxygen. Therefore, the blood will leave the lungs under-oxygenated. In cases like this, the patient's O2 sats will be lower. So your ABG pattern, you'll have hypoxemia. You could have a normal or a decreased partial pressure of carbon dioxide if it's compensating. But again, the key point, a lot of times these patients will have low O2 sats and they'll need supplemental oxygen. So if you have a high VQ mismatch, this is normally seen when the ventilation is greater than the perfusion. So air can reach the alveoli, but little or no blood flow is reaching the alveoli. This is almost kind of considered like the ventilation is wasted. Some examples of this could be PE, severe hypotension, and emphysema. You know, as I'm reading through this, the main thing that jumps out at me, or what I could recall, was probably severe hypotension. You know, if you have a patient that is bleeding out, so an emergency or trauma that's bleeding out, the oxygen may be there, but the blood flow may not. So from a physiological standpoint, you can have a normal or high alveolar O2, but no blood available to pick it up. Your ABG pattern can also show hypoxemia, but it will show a respiratory alkalosis. Common also may see a reflex hyperventilation trying to get more air or oxygen to the area. Key points additional point, these patients also require supplemental oxygen. So 3 is a true shunt. 1, the low VQ state was shunt-like, but 3 is a true shunt, and it is an extremely low VQ mismatch. So you have perfusion and absolutely no ventilation. Blood completely bypasses the ventilated alveoli. This is seen in ARDS, also seen in a large pneumonia with a consolidation. It can be seen also in an intracardiac right to left shunt. Key feature, the O2 sats do not correct when you place them on oxygen. And this is another little diagram that goes into a little bit of, kind of summarizing some of the VQ extremes. Again, I think I just want you to be aware of COPD, pulmonary embolism, and pneumonia. So the pneumonia would be, the pneumonia and the COPD would be like number 1, the low VQ shunt like state. So it's a low VQ mismatch. The PE is a high VQ mismatch. And the shunt down here, I think the most important thing to remember, the VQ calculation is 0. There's no ventilation. Next, I'm going to go into talking about the different pulmonary diseases. I break them up into 3 categories. You have obstructive, restrictive, and vascular. This slide does correlate with your instructional learning objective 2. So let's just go ahead and get into it. Some of this is, you've heard it in earlier lectures. I think Dr. Lawrence touched on some of these as well. And then a lot of it is bringing in module L as well. So in an obstructive state, there's an airflow limitation. A lot of times it may be difficult for the air to be expelled. Pathophysiology, you can have increased airway resistance is one way, from like a bronchial constriction, airway inflammation, or mucus plug. It can be due to air trapping, like I stated earlier, fail to release all the air during the expiratory phase of breathing. Also, some hyperventilation can cause this too, because you have the flattening of the diaphragm that's not able to contract as well to be able to help force some of the air out during the breathing cycle. If you were to look at pulmonary function studies on these patients in an obstructive state, remember your FEV1 to FEC ratio is less than 0.7. How does this result in your gas exchange? You'll end up having like incomplete alveolar emptying. So there will be a VQ mismatch. It'll be low, but you can see some hypoxemia or some hypercapnia. In advanced disease, you would have respiratory acidosis and you would probably see some hypercapnia, meaning you would hold on to your bicarb. This is seen sometimes in asthma, but it can be reversible. It's also seen in COPD, and it can be seen in emphysema, chronic bronchitis, and bronchiectasis. Next, with the restrictive pathophysiology, is reduced lung compliance, or expansion. Can be seen in diseases like fibrosis, chest wall limitations, or some neuromuscular weakness. If you look on PFTs, there is a decreased lung volume in the total lung capacity. The FEV1 and FEVC ratio is normal or increased. How does this affect gas exchange? There can be shallow and rapid breathing, reduced diffusion capacity, especially in the parenchymal disease, hypoxemia, especially with exertion, usually a normal partial pressure of carbon dioxide until late disease. Again, some examples include pulmonary fibrosis, sarcoidosis, pneumothorax, chest wall disease, or some type of neuromuscular disorder. And last, I'm going to talk about the pulmonary vascular perfusion disorders. There's impaired perfusion of the ventilated alveoli. So there's impaired pulmonary blood flow or gas exchange at the alveolar capillary membrane. Therefore, it's going to lead to a VQ mismatch. It can lead to a high VQ mismatch. This is usually due to reduced or uneven blood flow. So the alveoli are ventilated, but they're not perfused. If it creates a high VQ mismatch, this may lead to something called dead space. The consequences of this, you'll see hypoxemia, you'll see reflex hyperventilation, you'll see respiratory alkalosis, and you may see an increased AA gradient, and we'll discuss that a little bit later. Some possible examples of this would be pulmonary embolism, pulmonary hypertension, and pulmonary edema. Okay, this slide just illustrates pulmonary function tests with spirometry, what you would see, and this is normal. So with a normal inspiration, they will have good volume. On inspiration, peaks up, and then good on expiration. And this is how it tracks on the graph for your FVC. You have an obstructive process, the volume is decreased. And the plateau, there's a late plateau, not as early as up here, it's a late plateau. And then if you have a restrictive, the flow is still the same, but you can tell it's all restricted. The volume is even and low, even on the chart here, it plateaus appropriately, but the FVC is reduced. So next we're going to jump into talking about some of the disorders that you'll mainly see when you're out practicing that affect the pulmonary system. This does correlate with instructional learning objective 4. We're going to discuss asthma first. So the pathophysiology and triggers we'll discuss. There is an airway inflammation triad. Number 1, you have a bronchial spasm, smooth muscle contracts, and it will narrow the airway. 2, you have mucosal edema. So inflammatory mediators will increase the vascular permeability. And then 3, you have a mucus hypersecretion. So goblet cells and hyperplasia will plug the airway. You have some key mediators like IgE, histamines, leukotrienes, eosinophils, and T helper 2 cytokines. Common triggers include allergens, so dust mites, pollen, pet, dander, exercise, cold, air, viral, upper respiratory infections, GERD, occupational irritants, and NSAIDs and beta blockers. So patients will present with episodic wheezing, dyspnea, chest pain, and cough. Can often be worse at night or in the early morning. They'll present when you listen to them on exam, they'll have a prolonged expiratory phase. There may be a little tachypnea, and you could also see them using accessory muscles on acute exacerbation. If you have a patient that is in crisis and they have a silent chest, meaning you don't see any air moving, that's severe, life-threatening. You need to protect their airway. So diagnosis, you can use spirometry. The FEV1 to FEC ratio is usually less than 0.7, but it is reversed after using bronchodilators. The peak flow, there is a peak flow variability. You can also use the methylcholine challenge when also utilizing the spirometry. So stepwise treatment. So for rescue, patients can always use a short-acting beta agonist like an albuterol inhaler. It can be used as needed. For maintenance, patients can use a low-dose inhaled corticosteroid and a long-acting beta agonist. They could also, if that doesn't maintain their symptoms and they're having more exacerbations, like 3 or 4 a week, they could use a medium or high dose inhaled corticosteroid with a long-acting beta agonist. And if their symptoms are greater or they're noticing their symptoms, 5 to 6 times a week, it may be time to add one of the biologics for treatment. Kind of apologize for this slide. It's kind of confusing. So I'm going to break it down the way I kind of look at it, but I didn't mean for it to configure like this. So next we're going to talk about like the chronic obstructive pulmonary disorders. These two shouldn't have been up under this, and like I said, I apologize for that. I will correct it and send it out to you guys. But sometimes people do think about COPD and emphysema along with bronchitis. So, and their pathophysiology is very similar. So let's start with the emphysema, and they are also known as the pink puffers. It seems like they're always trying to suck air in, and they're all rosy. So pathophysiology, there's a destruction of the alveolar wall. A lot of times it's due to protease, antiprotease imbalance. It leads to loss of elastic recall, so there's air trapping and you get enlarged air spaces. There's also decreased surface area, which impairs gas exchange. These patients usually present They can be kind of thin and frail. They have a barrel chest. They usually have pursed lips when they're breathing. They have more shortness of breath than they do cough. They can present with weight loss. On chest x-ray, it looks like hyperinflation. And then they can have decreased breath sounds when you're listening to them. Some of the risk factors for this include smoking. Also, there is a alpha-1 antitrypsin deficiency that this can also occur in, especially if the patient is young, non-smoker, and it's mainly their their lower lobes. So as opposed to the pink puffers, you have the blue bloaters, and this is more so what you would see in the typical COPD patient. So you have chronic inflammation of the bronchi with mucus glands, hypertrophy, and hypersecretion. It's usually defined clinically by a productive cough for greater than 3 months of the year and for more than 2 years. Clinical features include a chronic productive cough, cyanosis, peripheral edema, frequent exacerbations, and rhonchi. You may hear a little rhonchi is not quite a crackle or wheeze, it's something in between. Risk factors include smoking, air pollution, occupation exposure, and recurrent infection. And so down here is like the treatment for gold standard. So staging can be done by doing your spirometry or your PFTs. If you do a bronchodilator and the FEV1 to FVC ratio is still less than 0.7, that confirms the diagnosis. What that means is it's not reversible. Your management, you want to get them to stop smoking. So smoking cessation is the number one thing. Treatment can be tailored. You can start off with a short-acting beta agonist or a short-acting muscarinic antagonist, PRN, depending on how frequent they have their symptoms. If that doesn't help to stabilize them, you can put them on long-acting beta agonist and a long-acting muscarinic antagonist. You can escalate and add the inhaled corticosteroids if they're having frequent exacerbations, and if their PaO2 or their partial pressure of oxygen is less than 55, they probably require oxygen therapy. And for those that are symptomatic, pulmonary rehab may actually be very beneficial. I've sent several of my patients in the past to pulmonary rehab, and it really, I think just the activity of it kept them from having frequent exacerbations. So next I'm going to talk about some of the restrictive lung diseases, such as um, pulmonary fibrosis. So classification of restrictive lung diseases is in two categories. You can have an intrinsic or extrinsic. Intrinsic is a parenchymal base. That's usually idiopathic pulmonary fibrosis, sarcoidosis, pneumocanosis from asbestosis, silicosis, or drug-induced fibrosis, and sometimes radiation fibrosis. The Extrinsic, which is extrapulmonary, can be due to a neuromuscular event such as myasthenia gravis, ALS, Guillain-Barré, some type of chest wall disorder like kyphosis or obesity, or pleural disease such as an infusion of fibrosis. So I'm going to focus a little bit more on the idiopathic pulmonary fibrosis. So epidemiology, men are affected more than women. Typically, is seen around the age of 50. It can be associated with smoking. Pathophysiology of it is related to alveolar epithelial injury. There is poor wound healing, which progresses to fibrosis or scarring. They can present with usual interstitial pneumonia patterns with fibroblasts, foci, and honeycombing. So I didn't include a picture of the slide, but when I go back and correct the slides on COPD, I'm going to add a couple of pictures, and I'll add pictures of COPD, idiopathic pulmonary fibrosis, and emphysema on there. Clinical presentation, they can present with a progressive dyspnea, dry cough, inspiratory Velcro crackles, and they actually do sound like Velcro, like someone is pulling Velcro apart. You can see digital clubbing of their digits, and they can have hypoxemia that worsens with exertion. So diagnosis is through a high resolution CT scan. You can see, again, like I said, the usual interstitial pneumonia pattern, which is the honeycombing and some traction. If you see this in a patient and they don't have any other diagnosis, it may be time to try to get some type of biopsy. Management is with the antifibrotics to kind of help slow the progression, but this is a tough diagnosis to give to your patients because a lot of them will end up on the heart and lung transplant list. You will give them supplemental oxygen. Again, the median survival is like 3 to 5 years from the diagnosis. It's a tough disorder. If the patients don't get a transplant, their survival, like it was stated, is probably 3 to 5 years. Okay, and on this slide, we'll go into a little bit of detail about some of the vascular disorders. First, I'll talk about pulmonary edema, and then talk about pulmonary embolism. So this correlates with instructional learning objective 6. So pulmonary edema, the most common cause of pulmonary edema is something cardiogenic. You may have a elevated left atrium or pulmonary capillary wedge pressure. So there's fluid transudation into the alveoli. So you have fluid that will become a transient into the alveoli. This can be caused by congestive heart failure, mitral stenosis, as well as fluid overload. In a non-cardiogenic state, this can be seen in ARDS, which is acute respiratory distress syndrome. There is a diffuse alveolar damage from sepsis, pneumonia, aspiration, or trauma. It increases the capillary permeability, and you have a protein-rich exudate comes out, which is different from the cardiogenic, which is a transudate. Presentation with both, they can have acute dyspnea, orthopnea, um, proximal nocturnal dyspnea. They can have a pink frothy sputum, bibasilar crackles, and hypoxemia. Management includes oxygen diuretics, usually furosemide, vasodilators, positioning, make sure they're upright, and treating the underlying cause. With ARDS, a lot of times you may have to protect the lungs with ventilation or while they're on ventilation with low tidal volumes. So we'll jump into talking about the pulmonary embolism. Um, there's a triad that goes with that as well, the Virchow's triad, where you'll have venous stasis, endothelial injury, and hypercoagulability. Risk factors include having a current or previous DVT, immobilization, surgery, malignancy, hormone replacement therapy, or oral contraceptives, pregnancy, and thrombophilia. Presentation, sudden dyspnea, patients will notice also pleuritic chest pain, may have tachycardia, tachypnea, hypoxemia, and hemoptysis. If it's a massive PE, patients will be hemodynamically unstable, and they could go into right ventricle failure. Diagnosis is made from CT angiography, which is the gold standard. You can also use a D-dimer to rule out if low pretest probability. You can also use the Wells criteria for risk stratifications, and I talked about that last week. Treatment is anticoagulation. You can do heparin, you can do warfarin, you can do low molecular. If it's a massive PE, you can consult vascular surgery. They can do thrombolytics for massive PEs. They can also do a thrombectomy. Some patients will require a IVC filter if they have a contraindication to anticoagulations. When I came through training, we used to put IVC filters in everyone. However, studies have come out that some IVC filters can actually promote a clot because it's a foreign body that's in the inferior vena cava. And so you can have little platelets clumping, and it can actually cause more, it increases your risk for another clot. Okay, so next we're going to switch gears and talk about the mechanisms of lung infections. And this correlates with, I'm sorry, this correlates with instructional learning objective 8 and 9. So, what is the mechanism of a lung infection? And we've gone over several modules talking about how a pathogen or antigen or bacteria or virus, how it enters our system, but we're going to recap it. So you have pathogen entry and colonization. So you can inhale the bacteria, virus, or the fungi. The pathogen will reach the alveoli. It adheres and it evades, so it overcomes normal defenses. It can impair your cough. You have the ciliary system that kind of will help cough the pathogens out, but it basically overcomes your normal defenses by impairing cough. It can damage mucociliary clearance, and it can cause immunosuppression. So once all those things have happened, it begins to replicate in the lungs. Then you'll have an inflammatory response. The alveolar macrophages will recognize the pathogen. They will release cytokines. It will increase the capillary permeability and recruit more neutrophils to come in to kind of help fight. Then the alveoli are now filled with exudates from all of this coming in. And I don't want you to forget about your immune response. Remember, you have an innate immunity, which is what's going on here with your macrophages, neutrophils, and complements. And then you have your adaptive response, which is our body's memory. So you have B cells that can produce any antibodies. You have T cells that kind of help mediate and kill the infection. And once this kicks in, the pathogen clearance begins. It starts to eliminate it. However, if there's not a balance and our system is unable to clear and it fails to clear it, that's when you'll start having the signs and symptoms of tissue damage and some gas exchange impairment, because you'll have inflammation of damaged alveolar and capillary membranes. The alveoli are probably filled with fluid, pus, or debris. This decreases the surface area for gas exchange. And then you'll notice you'll have a low VQ mismatch, which will result in some hypoxemia. If there's a severe injury, such as a consolidation, this can lead to sepsis, and it can also lead to ARDS like physiology. And this is just a little diagram showing you have the virus, this bacteria that's coming in. You have increased permeability of this membrane. When they come in, it's recognized. Your neutrophils start to recruit macrophages. They're trying to pull all this inflammation in. It will eventually be absorbed in your cell, where it will start to replicate into your innate and adaptive immunity will kick in to try to fight against that in order to protect us from the infection becoming any worse. Okay, and so I'm just going to briefly highlight on the most pertinent infections, which probably is going to be a pneumonia. And when I send you out a study guide, I'm going to probably break it down the way it was broken down to me in residency. But for right now, I just wanted to do major categories. So with pneumonia, you have different types. You have a community-acquired pneumonia. The common pathogen is probably strep pneumonia. I apologize for the alarm. My daughter is hypoglycemic. So the common pathogens for community-acquired pneumonia, you have your strep pneumoniae, Haemophilus influenza, the Mycoplasma pneumoniae, and Chlamydia pneumoniae. Key features: they'll have fever, productive cough, lobar consolidation. You will treat with microlid or doxycycline. I know some students have heard me say this. Community-acquired pneumonia was a board question on my recent boards. Treatment was doxycycline. I remembered it from sitting in on an infectious disease lecture from one of my colleagues at my previous program. So sitting in on a PA lecture. The next category is hospital-acquired pneumonia. You have to think about MRSA, Pseudomonas, Klebsiella, and Acinetobacter. It develops after 48 hours of being in the hospital. It requires broad-spectrum IV antibiotic. Remember, this is the one that has like the vancomycin and Zosyn as treatment. The third type of pulmonary infection when it comes to pneumonia is aspiration. You can see this. The organism is usually anaerobes or mixed flora. You think about the organisms that may be in the mouth or actually in the gut. Key features, a lot of times these patients may have some form of altered mental status, poor dentition, dependent lung segments. Treat them with amoxicillin or, amoxicillin sulbactam, which is augmentin. And then, I want you guys to remember the atypicals. A lot of times that depends on the presentation. It makes you think about that. So you can have mycoplasma, chlamydia, legionnaires, or any other viruses. But, I want you to think about the presentation, for instance. If you have a patient that presents with pneumonia symptoms and they've been around some type of water system, air cooling system, or hot tub, think about legionnaires. It's usually a gradual onset, dry cough, and you may have some extra pulmonary symptoms. You can also have diffuse interstitial infiltrates. And the last category is fungal. This is another one. You think about the presentation. There will always be a geographic component or the patient will be immunocompromised. So histoplasmosis, coccidioids, blastomyces, aspergillus. So what makes a patient susceptible? Advanced age, immunosuppression, smoking, chronic lung disease, impaired cough reflex, if they're altered and they're unable to cough on their own, mechanical ventilation, and then just a post-viral state. Again, some of the signs and symptoms of patients presenting with pneumonia: you have fever, productive cough, dyspnea, tachypnea, clerk chest pain. They can have crackles or bronchial breath sounds, dullness to percussion over the consolidation, and a leukocytosis. Do want you guys to understand, the importance of TB. Again, we touched on it some in the infectious disease module. Pathogenesis is the Mycobacterium tuberculosis. It's an acid-fast, aerobic, slow-growing bacillus. It's transmitted via an airborne droplet vector or nuclei, I'm sorry. The primary infection, you usually inhale the bacilli. It goes into an alveolar macrophage where it is engulfed it forms something called a gong focus, kind of mid-lung. And then there's another cell-mediated immune response where a granuloma will form around it, and also will have some necrosis. So the gong complex usually will show up on a chest radiograph, as well as some hilar lymphadenopathy. There's two types that we treat now. We have latent TB infection, or LTBI. It's contained by the immune system. However, they will have a positive PPD, but asymptomatic, usually non-infectious, and normal chest radiograph. And then you have active or reactivation TB. They'll have a chronic cough greater than 2-3 weeks, will have symptoms of hemoptysis, could have symptoms of night sweats, fever, weight loss, and fatigue. You'll have the typical upper lobe cavitary lesion on a chest radiograph, and immune suppression is the key if it has been reactivated. So patients who are on therapy that will suppress their immune system, and I can give myself as an example. I am on infliximab or Remicade or Inflectra for my Crohn's disease. I've been on it since 2007. Yearly, I have to go through testing to make sure I haven't been exposed to TB, or before starting, I had to make sure I wasn't a carrier or latent TB. But this is something that, I have to test for yearly, just to make sure, because the medication is a biologic and it can suppress my immune system and put me at increased risk for TB. So your diagnosis, is a tuberculin skin test. It's still effective. However, the quantiferon TB, I think, is more so the gold standard now. Most practices have gone away with the skin test because they did have a high ratio of false positives. So if either one of these come back positive, you have to do a confirmatory test with chest x-ray and sputum smears. You'll try to get 3 AFBs. I'm sorry. Yes, the confirmatory test is a chest x-ray, as well as obtaining sputum cultures, which you'll be looking for acid fast bacillus. You have to get 3 cultures because sometimes this is a fungus, and sometimes it takes longer to grow. The mycobacterial culture is a gold standard, and also the nucleic acid amplification test is a very highly sensitive test that can be also utilized. Your chest radiograph will show upper lobe cavitations, infiltrates, hilar lymphadenopathy, and a miliary pattern, meaning it's disseminated. Sometimes patients can have lesions in their vertebrae. I also had a patient that had acute on chronic kidney failure and was noted to have TB in his bladder. That was disseminated TB. So treatment. So there are different treatments. For latent TB infection, you can have the isoniazid for 9 months. You have to make sure you take vitamin B12 with it. Or you can do rifampin for 4 months. Or you can do INH and rifampicin for 3 months. That was the old school method of treating. And no, the single treatments may be longer months, but I found that for compliance wise, patients seem to do a little bit better with the one regimen, even if it's a longer duration. For active TB, you do an intensive phase for 2 months. That's with rifampin, isoniazid, pyrazinamide, and ethambutol. And then you do a continuation phase for 4 months with rifampin and isoniazid. Now, some of the key side effects, and this is something I always tell patients, before I prescribe anything to my patients, I would always look up the side effect profile. And I find that if I tell them these are the common side effects, doesn't mean that you're necessarily going to have them, but these are the side effects that were reported. If you have anything like this, please notify us and we can see if we need to adjust regimen. I find if I warn them of that, a lot of times if they do have some form of a side effect, they still take the medication. They'll just endure it until their body gets used to it. So just be familiar with your, medications and the side effect profile when you're educating your patients. Well, the INH can cause some hepatotoxicity and peripheral neuropathy. That's why you have to make sure these patients take vitamin B6. Rifampin can cause hepatotoxicity. It can also cause body fluids to turn orange. If you've ever taken rifampin, like for an antibiotic for any reason, your urine turns orange, your tears turn orange. It can also affect the CYP450, so it can affect how well your other medications may actually work. The ethambutol can cause some optic neuritis, and the pyrazinamide can cause hepatotoxicity and hyperuricemia. Okay, and so the last few slides that we're going to talk about, we're going to hit on what happens when you have a pulmonary infection and it doesn't improve and it continues to progress. So basically from pulmonary infection to sepsis. And I do want you guys to remember the definition of sepsis. That was in one of Dr. Lawrence's first slides or first lectures. Sepsis is basically SIRS with a confirmed or a suspected infection. And then your SIRS criteria, you have to have 2 or more findings, meaning temperature greater than 38 degrees Celsius, heart rate greater than 90, respiratory rate greater than 20. So a pulmonary infection, the pathogen reaches the alveoli. You have a local pneumonia begins, the alveolar macrophages activate. You have this systemic inflammatory response, sepsis. You have a dysregulation of cytokines that are being released, tumor necrosis factor alpha, interleukins 1, interleukin 6 will surge. You may have a local infection that now has become systemic. This can result in endothelial activation, meaning you'll have more permeability in the capillaries and you'll have a loss of vascular integrity. The key point for this: sepsis amplifies a localized lung infection into a systemic inflammatory disease. This can lead to lung injury, which will result in gas exchange failure. So you'll have the alveolar capillary damage from the endothelial injury. Protein-rich fluid leaks into the alveolar, and surfactant dysfunction can actually cause the alveolar to collapse. This will lead to a VQ mismatch or shunt. It can be perfused but not ventilated. It can also lead to what's known as a low VQ shunt or a true shunt from a physiological standpoint. It can lead to severe hypoxemia, which decreases the partial pressure of oxygen or the PaO2. You can have a refractory to which will cause the patients to be refractory to supplemental O2, and you'll have this increased AA gradient. So key points: hypoxia and sepsis often does not correct with oxygen, and it's because they're already perfused. It's just not getting enough ventilation because there's so much alveolar collapse. So the clinical and the acid-base consequences: early sepsis, you'll notice fever, hypoxemia. They may have hyperventilation or they may have a respiratory alkalosis trying to, correct the underlying acid-base disorder. As the sepsis progresses, you can get tissue hypoperfusion, which will lead to increased lactic acid, and then it will result in a metabolic acidosis. The clinical outcome would then be acute respiratory distress syndrome, and this is where the lung compliance, you have decreased lung compliance. This is known as a stiff lung, and this is where mechanical ventilation is required. So the most important thing from these last few slides is that a lung infection can lead to sepsis, and sepsis can lead to ARDS, which ends up being a failure in the VQ system. You'll end up having a really bad mismatch. Initially, in early sepsis, they can have some respiratory alkalosis trying to compensate. Later, they end up with a metabolic acidosis. So these are the ones that usually will have that mixed base disorder. So sepsis, again, converts pneumonia into a diffuse inflammatory lung failure. Hypoxemia and sepsis is due to a shunt, not necessarily hypoventilation. And ARDS basically means severe sepsis is now affecting the lungs. So how do we pull all this together? The lungs are first line compensatory organ for metabolic acid-base disturbances. Peripheral and central chemoreceptors can sense changes in the pH, PaCO2, and PaO2. The medullary respiratory centers adjust ventilation within minutes, increasing minute ventilation and acidosis, meaning it's going to blow off that O2, and decreasing it in acidosis to retain the CO2. This is faster than the renal compensation, but it cannot fully correct pH. Some take-home points for respiratory compensation: if you have a metabolic acidosis, which is a decreased pH, those receptors will sense that. your body will start to hyperventilate, trying to blow off the CO2. You will use the Winner's formula to predict if you are accomplishing the predicted or expected partial pressure of carbon dioxide. With COPD, you can have a respiratory acidosis. This is due to chronic CO2 retention. So you have a high PaCO2, but you can have a low pH, again known as respiratory acidosis. The kidneys will compensate by increasing the bicarb reabsorption over days. Be cautious with oxygen in this, because in COPD patients, sometimes they need a lower oxygen level to give them the drive to breathe. I'll put that concept probably in one of our review packets. And then the third thing, PE, you can see a respiratory alkalosis. With PE, you have a VQ mismatch and you can have some hypoxemia. This will cause a reflexive ventilation. You can have decreased PaCO2 and decreased respiratory alkalosis. The ABG will show an increased AA gradient with hypoxemia and hypocapnia. This is just a summary slide. You guys can go over this at your leisure. It's just some additional key takeaway points. If you have any questions about the lecture, please feel free to give me just shoot me an email. I will have a study guide for last week and this week to you this week to go through, and so you can start processing some of this information. Thank you for your time and thanks for listening.